Good evening. It's my pleasure to moderate and introduce this UROwebinar on PSMA PET and the role of PSMA imaging to spare an extended pelvic nodal dissection in high-risk prostate cancer patients. This webinar has been organized by the European School of Urology, the EU section of Oncological Urology, and the Guidelines Office. And we will discuss the growing role of molecular imaging, PSMA PET in particular, in the preoperative staging of high-risk prostate cancer patients, candidates for radical prostatectomy. The main aims are to scrutinize the benefits, pitfalls, and challenges of this novel staging pathway, and to examine the current evidence and guidelines on the indication of a pelvic nodal dissection in high-risk prostate cancer patients preoperatively staged with a PSMA PET. With this, I'd like to introduce Professor Burger, who will give a talk on the role of PSMA PET from biology to clinical context. Thank you.
Thank you very much, Giorgio, and thank you for having me. It's a great pleasure to be here to speak about PSMA PET in the context of biology to clinics. These are my disclosures. So I will start right away with where I think PSMA and the biology of PSMA really has an impact on how we see it for primary prostate cancer. In the second part, we will look on how PSMA PET-CT impacts staging of lymph node metastasis, and then also discourse a little bit into how we could further use PSMA PET-CT for improved stratification of patients for lymph node dissection using nomograms. The biology. If you look at PSMA stainings, then very often you'll have this immunohistochemistry staining level 1, 2 to 3 of cells that are more here on the epithelium, then here more also in the cytosol. What you will also recognize is, if you look at a lot of prostate cancer samples, is that not all the tumors are homogeneously positive or negative, like in those two samples. Very often we encounter lesions that are 90% positive, have focal areas of no uptake, or are plus or minus completely PSMA negative. When we looked into how this PSMA immunohistochemistry patterns have an impact on imaging, we interestingly found that it's not so much the immunohistochemistry staining 1 to 3 that is really correlating with PSMA uptake on PET. It indeed is the PSMA negative area. So if your tumor has an area of more than 20% PSMA negativity, which is not that much, I was surprised that this number here, we assessed this by an ROC analysis, was so low, then your SUV uptake is quite low, sometimes really just around background. If your tumor has less than 20% negative areas, not so surprisingly, then you can have very intense PSMA accumulation. So the heterogeneity, and especially the PSMA negative disease, has a big impact on how we see the primary tumors. Now, let's dive a little bit deeper into the PSMA and immunohistochemistry story and bring the TMPRSS-ERG story into it. TMPRSS-ERG mutations have been around, have been studied, whether we can diagnose prostate cancer with ERG immunohistochemistry or not. It was then dropped down because too many prostate cancers were ERG negative. What we now see and found is that if your ERG is negative, you are much more likely to be strongly PSMA positive. So ERG negative disease has significantly higher PSMA uptake compared to ERG positive disease. And ERG somehow even seems to regulate the PSMA, even if the PSMA is strongly positive and the ERG is positive as well, our SUVs are still lower compared to the patients where we have strong PSMA positive tumors without ERG mutation. So understanding the underlying biology of the disease might improve our understanding how we have to interpret the PSMA results. If I have an ERG negative patient and I do not see lesions, then I'm much more convinced that we definitely don't miss them because they usually are much more PSMA positive. So that brings me into this illustration that shows that we have to think about different groups if we talk about PSMA. We have a large group which is strongly positive, then a group that's mixed, and we have some patients that are completely negative. However, these are the lower ISOP grades. In ISOP 3, it's maybe even a little bit more than 15%, but overall at staging, we can say those really negative patients are around 15 to 20%. So does it mean in 20% of the patients we don't see the lymph nodes at all? I would not say so, because we also know that this PSMA is the best marker for aggressiveness. It's better than ADC or T stage. It correlates very well with the ISOP grades in multiple different studies. And we also see here that the PSMA negative tumor area is much less frequent in patients with high Gleason grades. So the aggressive tumors seem to be more PSMA positive. And we even sometimes see this in patients with just mild uptake in the primary, but then very intense uptake in the lymph node metastasis. It happened to me very recently that somebody was not sure then whether the lymph node really correlates to the primary tumor because the primary tumor had lower uptake than the nodal metastasis. This is exactly what happens when you select the most aggressive part of the primary that then does the lymph node metastasis. So this is a quite common pattern to have more uptake in nodes compared to the primary tumor, especially if the primary tumor is quite small. Now, how does this impact our clinical staging skills? I think with this paper, the ProPSMA study, it all started that we now use PSMA PET for staging in our patients. What we see, or what we saw, is an excellent specificity and also a significantly improved sensitivity over conventional staging. Now, looking at the sensitivity here with 85%, this is tremendously positive and promising, but I think it's overestimating the sensitivity we see in PSMA PET. And one explanation might be that only 23% of those patients really had an extended pelvic lymph node dissection. So in many of the patients, this was not performed, and therefore there is a completely different gold standard to a lot of other studies that have been done later on. Some will also be discussed later on, but just to give you some ideas, I think a sensitivity around somewhere 60% is quite reasonable. This also has been shown here in this group where 40% were upstaged to PN1 that was missed on regular PET-CT when you use then intratumoral nanocolloid for SLN biopsies. So overall, I think the estimation 60% is quite good. And this 60% is about as good as if you do classical nomograms, with the advantage that you see the lymph node metastasis, that you can see the site, and that you might be able to really resect it. Next generation nomograms incorporated also next generation imaging. Here, using PSMA, but only as yes, no. So if the node is positive on PSMA, that has an impact on the nomogram. And they also incorporated the multiparametric MRI parameters into this. And improved, the AUC for the prediction of lymph node metastasis. Now, I think we can even go a step further. We can do an ensemble model and not only take the positivity into it, but also PSMA quantitative parameters, because we know that PSMA is so predictive for aggressiveness of the tumor. And with this ensemble model, although it was in a much smaller cohort, we had 170 from the University of Munich for development and only 90 from the University of Zurich for external validation. We also reached really quite a nice AUC, even slightly higher than with the nomogram that just incorporated PSMA as positive or negative. So with this, I think PSMA is not positive in all patients. We have our limits, but it is associated with aggressiveness. And I think most of the patients with lymph node metastasis have some PSMA expression. To see pathologically enlarged nodes without PSMA expression is super rare. Overall, I think we have to admit 60%, if you really take micrometastasis into account as well, is the rate we can get. And lesions below 4 millimeter are the ones we probably miss. So incorporating of quantitative PSMA parameters, I think, would be a very nice tool to further improve nomograms to predict patients for selection for lymph node dissection. And I'd like to end this with something we imagers heard very often, that you should not perform just because of improved diagnostic accuracy, but really you should perform diagnostic tests because you improve outcome. And I would add, especially if they also cause harm to the patients. And with this, I'd like to thank you for your attention, and I'm happy to take questions.
Thank you very much. And the floor is open for discussion, and it was a very great presentation. I'd like to invite everyone to use the chat and the question and answers portal. We will answer using the chat, and we will select the question which deserve further discussion by our experts today. I have actually one brief question for Professor Berger, and it's about the role of a variant histology in the presence of an uptake at PSMA. And the second question is, what is the most important factor to determine PSMA positivity? The size of the metastasis, and we know that there are limitations related to the spatial resolution of a PET CT or PET MRI, or PSMA expression, as you discussed earlier.
Yeah, I mean, that I'm starting with the second question. I think that is always a combination question, because you have to imagine it is I have seen patients where I really could detect lymph node metastasis on pathology. They had a diameter of not even 2 millimeters, but they were super strongly PSMA heavy. Other lesions just do not express PSMA that much. So overall, I think those 4 millimeters are a cutoff that comes again and again if we go through the literature, that this is something where we really get to our, let's say, borders of detection. In some accepted cases, you also can detect smaller lesions. Your first question regarding the role of histopathology, sorry, I missed a part of it. Could you repeat this?
We have patients with a variant histology, and we know that PSMA aggressiveness can also be related to, for example, as you showed, grade group or let's say ESOU. But we have also patients with a variant histology, and in these cases,
neuroendocrine subtypes.
Yeah, or neuroendocrine, intraductal, or all these variant histologies. Do you have any recommendations regarding also the use of alternative tracers if these tumors are not expressing actually PSMA?
Well, that's a very good question, and I think a very difficult to answer because we are really lacking data. It's a rare group, and I've seen neuroendocrine tumors with intense PSMA uptake. I've seen more neuroendocrine subtypes without PSMA accumulation at all. So it's not a clear yes, no, but it's a risk. So as soon as you have a suspicion for such a subtype in your biopsy, I think it is probably still PSMA we should do. I have no data that FDG would be better in this subtype. If the tumor is super aggressive and you see nothing on your PSMA PET, then of course you should think more about an alternative way to stage, be it then only based on morphology, or if you have the possibility, and that again also is limited a little bit to availability, but let's not forget full line. And also if it's a super aggressive tumor and it's a neuroendocrine variant, I've had some cases that were most positive on FDG, but these are then really the tumors that are behaving very, very nasty. Not really like we know in prostate cancer.
We have a question from the US actually, and it's about the role of PSMA to select patients to be considered for surgery without a prostate biopsy. So do you have any experience on this, and what is your opinion?
Well, no. I know that in China they are doing it. So if you have an ESOU max above 12, you can go to surgery right away. I see the rationale behind it, because the likelihood that you have a significant cancer is really, really extremely high. Experience, no. So we don't do it in our institution. Patients get a biopsy, especially also, sometimes you also have to see the PET just comes after the biopsy, because we first need to have the high risk disease before we then go on to the PSMA PET. So it's a little bit, yeah, you can then debate if we see some very hot spots in the PSMA PET after the biopsy was only at least in 3+4, for example, in the MR guided biopsy, whether you then should go right away to surgery. But even this we don't do. Usually the patient gets a new targeted biopsy to this PSMA positive area. But again, at the end, I think to skip the biopsies at all, I think we have very limited data.
And I have one last question, actually. You presented some nomograms based on the SUV max or other quantitative parameters. And we also know that these parameters are changing based on the tracer, based on the type of acquisition. And can we rely on them? Should we validate them using different tracers? Should we validate them internally using our protocol and our tracers?
Yes, we have a variance in our PSMA accumulation. That's no question. But let's face it, ADC values are just as variable as well. And we are very used to say, oh, more aggressive, less aggressive. At the bottom line, I think I would not say clear-cut cutoffs like 7.6 you do X, 7.5 you do Y. However, if somebody really has a large, very PSMA-avid tumor, he just has a much higher risk to have nodal metastasis. And I think we just need much more work how robust these values are, despite all this heterogeneity. Having said that, yes, the traces are variable also in the primary lesions. However, there it's not that bad. I mean, the primary lesions, the differences in uptake, if you compare to lymph node or bone metastasis, I think it's not that great. And at the bottom line, you always have the variances and cross-validation, and especially also calibration of scanners and protocols. Yes, we'll still have to improve there, but the prediction of PSMA is still very good despite all those variables we have in it.
Thank you very much. And with this, I'd like to move to the next part of our webinar, which is actually a debate on the role of an extended pelvic lymph node dissection in patients with prostate cancer who were preoperatively staged with a PSMA. We have Dr. Stranne from Göteborg discussing the role of PSMA to spare an extended nodal dissection.
Thank you so much, Giorgio. PSMA PET CT can spare extended pelvic lymph node dissection. That would be my standpoint in this. And I have no potential conflict of interest when it comes to this. To answer this question, we first have to start off by asking ourselves, why do we perform an extended pelvic lymph node dissection? And this can be of different reasons, but the first one would be to improve oncological outcome. And does extended pelvic lymph node dissection improve oncological outcome? To answer this question, we have 2 randomized controlled trials and 1 review at least. There are a number of other studies, most of them in this review. And when it comes to this, we have the 2 randomized controlled trials. We have the Distinguished trial published in 2021, 300 patients, intermediate or high-risk prostate cancer, were limited versus extended pelvic lymph node dissection. We have the Touget trial from New York, also published in the same year, 1,440 patients, also scheduled for radical prostatectomy and lymph node dissection, randomized between limited and extended pelvic lymph node dissection. Both had biochemical recurrence as their main endpoint, and there was absolutely no difference with up to 7 years of follow-up in these studies. If you look at the review, it's 66,000 with over 275,000 patients included in this review. There are a few years back, but so far no other studies have been published that contradicts this. And their conclusion was a direct therapeutic effect is still not evident from the current literature. So, but you may say, at the ESOU, the one who attended there, they claim that extended lymph node dissection decreased the risk of M1 disease, and that would be a different endpoint than the biochemical recurrence. And this is true. There was an update of the Touget trial from Sloan Kettering, and it was in a game-changing session called Lymph Node Dissection in Prostate Cancer, Is the Book Closed? And in this session, you had to go back and see what was this trial. It was a randomized controlled trial, single center, Memorial Sloan Kettering. It's clinically localized prostate cancer, no systemic METs, and scheduled for radical prostatectomy. It's a 1-to-1 randomization, limited versus extended, and the primary endpoint was biochemical recurrence. There were a number of secondary endpoints, of which one of them was the incidence of distance METs. The current analysis was a longer median follow-up and a median follow-up of 4.2 years. And if you compare the two groups, they are surprisingly similar with a median number of nodes, and which they should be if they're randomized. But the surprising thing is the median number of nodes removed was 12 versus 14 in the limited versus the extended group. But still, they are randomized to this. And if you look at the outcomes, biochemical recurrence, still no difference. Hazard ratio 1.05, and that would with a p-value of 0.3. But there was a difference in the incidence of metastasis, and especially of the incidence of distant metastasis. But the interesting part was that there was no difference in the negative patients. In the node-negative patients, there was absolutely no difference at all. The whole difference was driven by the N+ patients. So there was no difference in persistent PSA between the limited and extended group, no difference in PSA dynamics at biochemical recurrence, but still you could see this difference. And this is not a peer-reviewed published study. We were still waiting for that to come out. But alternative explanations that we could have for these results could be selection bias. The fewer nodes you remove, the more bigger metastases you need to be N1, and these more advanced tumors are more likely to lead to M1 disease. None of these patients, and that is the important part, had undergone PSMA PET CT. They were only negative on MRI, CT, and bone scan. And there was one on many secondary endpoints. So this could be also a random error. Nevertheless, this is very interesting in the future, but so far, extended pelvic lymph node dissection is for staging and nothing else. But does it cause harm? As we heard on the previous talk, yes, it may do that. In the study from Briganti and co-workers, they looked at 767 patients, of which 1/5 had a complication after a lymph node dissection. In another study, 3,544 patients followed prospectively, non-randomized between open and radical prostatectomy and robot-assisted, of which 547 had lymph node dissection. The risk of having a complication was up to 10 times higher, and the risk of having a DVT or pulmonary embolism was up to 10 times higher if you took the lymph nodes out versus if you didn't. So the risk of having potentially lethal complication was up to 10 times higher. What about other complications? Lymphocyl, approximately 10%. Lymphedema, between 4 and 10%. And this is a patient that had 14 lymph nodes removed, of which none of them were positive. And I can tell you that he's not a very happy patient. We basically ruined his life by taking these 14 nodes out. So does it cause harm? Yes, in the same review, the majority of studies show that pelvic lymph node dissection is associated with worse intraoperative and perioperative outcomes. And what did we learn in med school? We learned that primum non nocere, first do no harm by Hippocrates, right? So no oncological benefit and it causes harm. But is PSMA PET an alternative? Yes, there are a couple of benefits of this. The staging will be there before you choose your treatment, not after you had already done the treatment. It's a high specificity, as we heard beforehand. And it's reasonable sensitivity. You heard that it was even up to 60%, but the higher the PSA and the higher the ESOU grade, it's higher. And it's a safe and valid option of high risk of N+ on nomograms, high PSA and high ESOU. Neoadjuvant adjuvant treatment may be administered, and this is yet to see how to do this, but this may be administered in a neoadjuvant settings even. So the guidelines views these days is that it's correct that extended pelvic lymph node dissection provides accurate lymph node staging, but they may miss lymph node metastasis. It's not 100% bulletproof. Preoperative PSMA PET CT, more accurate than conventional imaging for staging generally, but it may miss, as we also heard, smaller lymph nodes, especially smaller than 5 millimeters. So what about nomograms that we discussed? If you look at a patient with a high-risk tumor, he's 51-year-old, he's healthy, he has a PSA of 17, he has a clinical T2B disease and a Pirates 5 lesion with Gleason grade 4 in 5 out of 15 cohorts, and it's cribriform. So what happened with the old nomogram? We have our moderator, Dr. Gandaglia, and he published this a few years ago. This man would have about 23% risk of having an N1 disease. And the way to find out was to do a lymph node dissection. Yes, but with the same, with the new nomogram that Dr. Gandaglia also published here last year, the same man with a negative PSMA PET would have about 3% risk of N1. And very few of us argue that we should put 97% of the patients into an unnecessary risk. 3% risk of being N1, it's 97% chance of being N0 and would have this lymph node dissection in vain, risking in 1 in 5 of having a complication and pulmonary embolism and lymphedema, etc. So the conclusion I would make that if use PSMA PET CT if available, and you can or even should absolutely skip extended lymph node dissection if it's negative. So are there any situations where we should or could perform extended lymph node dissection? Yes. We could do it during radical prostatectomy in selected PSMA positive patients. We don't know if there's any oncological benefit, but if we're ever going to prove this, we have to do this in the patients that has lymph node metastasis. However, I would say that this should be done within controlled trials. As a secondary procedure after radical prostatectomy in selected PSA positive patients, you have a negative PSMA before the radical prostatectomy, you perform the prostatectomy, and you have a persistent PSA. These are maybe one of the patients that have negative PSMA PET because they didn't show up on that one. And it's absolutely plausible to do a lymph node dissection 3 months later or later on if you want to. But we are in desperate need of studies when it comes to these, because we really do not know as if today. We only know that lymph node dissection causes morbidity. Thank you so much for your attention.
And so it is always difficult to speak after the guidelines and mostly against the guidelines, but I will try to do my best, of course. This is my conflict of interest. So this is my agenda. I will start with a few considerations, probably from a different perspective. Then I will go through the limitations of the molecular imaging and end up with a possible solution to the never-ending conundrum, PND, yes or no. So point number one, when is an extended PND useless? Either when no positive lymph nodes are found, and this pertains to the staging uselessness, or when no survival benefit is achieved, and this is, of course, a therapeutic uselessness. So back to the first scenario. This might be true, so no positive lymph nodes are found, but please be aware of this paper, extended PND. We know everybody that it is the most accurate staging tool, but is so accurate that it can remove metastasis in the nodes, even though the report of your pathologist shows no positive nodes. How could it be possible? So in this study, based on this study, approximately 1 of 9 patients with negative lymph nodes on conventional histology do indeed harbor positive nodes detected by immunohistochemistry. So these are not trivial. The biology of these occult lymph nodes are not trivial because, as you see, these patients had a worse prognosis. And also, take-home message of this study is 1 out of 3 of these patients with positive nodes, of course, had no BCR at the long term. But one might argue, okay, this is an old study, so conventional imaging era. What will happen in the contemporary PSMA era? And look at this study. All patients staged with molecular imaging and all patients with N0. And then approximately 1 out of 3 of these patients, when undergoing a sentinel lymph node biopsy using a different tracer, were found to be PN1, and so were upstaged to PN1. So I think there is a problem here. And back to the second scenario, survival benefit. This, of course, is a more intricate and complex issue. Professor Stranne highlighted this trial, but the limited versus extended PLND, although the memorial update comes to my side for this debate, but they are not answering the right question. So the right question is trials, and we need desperately trials, I agree, with extended PLND versus no. Such trials are there, some of the old conventional imaging era and some of the new PSMA era, so PSMA triaged, and they are actively recruiting patients. But to me, the real practice-changing trial would be, hopefully, sometime the trial testing no nodal treatment versus immediate versus delayed, of course, in case of positive lymph nodes detected in the contemporary era. Point number 2, I think this is the best evidence we have so far for the performance of PSMA PET in predicting lymph node dissection. And the bottom line message is the figure on the right, and you see clearly that the higher the prevalence of lymph node invasion based on a priori clinical risk, the lower the negative predictive value. So the sensitivity, we know it's a big issue for this molecular imaging. This is, of course, better than the conventional imaging, the sensitivity, but still suboptimal. And so if you use PSMA PET to decide whether to perform a lymph node dissection, well, in men with a higher risk, a priori risk of lymph node metastasis, for example, 20%, this will lead to missing potentially positive nodes in really a higher proportion of our patient, 1 out of 4. So I think this is another problem here. I want to draw your attention to this issue that probably is not often emphasized in the literature or in our meetings or in our talks. Of course, we see a dramatically decreased accuracy in the performance of PSMA PET and other, of course, radiological examination when we go from a patient-based analysis to a lesion-based analysis. So this, I would say, fantastic performance of PSMA PET dramatically drops when the studies are stratified by a lesion-based analysis. This is quite important. And which nodes are we missing with PSMA? Exactly the nodes that are frequently and more frequently encountered in today's patients. So up to 60% of patients that are undergoing a radical surgery and a pelvic lymph node dissection have the nodal method that we know now that are those with a size lower than 5 millimeters that of course are frequently missed by the PSMA PET. And again, these are not negligible biology. So these lymph nodes are cancer. Point number 3. As a PSMA PET really improved the risk stratification, one would tend to say yes, of course, but consider this. These are, as already shown, the first generation mammograms. So old era, conventional imaging era. Please look at these 13 percentages here. The number of avoided PND, approximately 60% at the cost of missing 1 to 2% of lymph node invasion if you set a cutoff of 7%. Then, of course, we are fortunate to have the new generation mammogram. And of course, this is one of them and the other, so published simultaneously a few years ago. And as you see here, again, using PSMA, again, a similar proportion of lymphadenectomy avoided at the cost of missing slightly higher, or we can say similar rate of lymph node invasion, provided that the cutoff is more or less the same. So I think we have already another problem here. And I think you would agree with me that nomograms are really fancy, are really cool, but probably difficult to apply in everyday clinical practice, because of course we know that they need an external validation, a proper external validation before we use. We need to know the calibration, and probably they need a periodic update. So point number 4. This is again a common issue in the clinical practice. And PSMA PET world is not all black and white, and we don't have shadows of gray, of course. There have been multiple attempts to remove the subjectivity of the reader, and so to try to standardize the interpretation reporting of the PSMA PET. But of course, we have a large area of so-called indeterminate lesions. And for example, I'm showing here one of these. So lymph nodes, abdominal lymph nodes or pelvic lymph nodes. And we are not sure whether these are METs or not. And so probably if we tend to report this, contrary to the bone lesions, these indeterminate equivocal lesions, most of them, when it comes to the nodes, are really positive. So if we trust if we use the PSMA, and then we see these nodes and probably say PSMA, we cannot call everything that has some light as positive. So probably we avoid doing a lymphadenectomy and leave metastasis in the body. But I think to a broader topic or to a broader issue and more alarming, we do desperately need the real-world performance of the PSMA PET. And it is important to remember that all these figures come from centers of excellence. So people using PSMA PET really for 10 years. But I expected, I anticipated that the performance in community hospital across the globe is really, really inferior. And this has to do with the multiple variability factors that more or less, as for the prostate MRI, are happening. So that is, of course, one thing that we lack, but presumably we cannot rely across the globe on this molecular imaging so far. So a solution. Some people are proposing the strategy based on the sentinel node biopsy, which is living probably a second life right now in the PSMA era. This, I think, is the most convincing evidence that we have using an old era tracer, technetium aneuploid. And as you see here, the performance characteristics are really wonderful. So what can we expect from the modern era? There are multiple and intense research in this area. I'm just quoting here one of the multiple studies published or in progress. This is, of course, an interim analysis. This is a modern concept of the sentinel lymph node biopsy applied to robotic surgery using intravenous PSMA tracer, not intraprostatic nanocolloid, with multiple claim advantages. And you see here, of course, only 12 patients because it is an interim analysis. But the only micrometastasis, the only missed case of lymph node invasion, guess what, was right the 3 millimeter micromet. Of course, this is a fascinating technology, but that poses several challenges. As you may imagine, it is a super modern technology requiring logistics, so not applicable to every urology department. There is, of course, a learning curve, some concerns on reproducibility. We are trying to improve with the better surgical navigation tools. Of course, this is quite costly. So my conclusion, extended PLND is the most accurate staging procedure in 2024 across the globe. But I do agree that the old one-size-fits-all concept or dogma should be over. For sure, some patients will profit more than others from this staging tool. Modern molecular imaging may serve as a tool to improve the clinical risk stratification, but again, we have a suboptimal performance test sensitivity, especially for micrometastasis. A potential strategy to avoid extensive dissection in everybody, but keep the window of staging/curability in select patient might be right, the strategy based on the sentinel lymph node biopsy guided by molecular imaging. And in absence of high-level, high-quality evidence, I think that a case-by-case discussion within our MDT board is the way to go. Thank you for your attention.
Thank you, Gianluca, and congrats. I have a, let's say, question for both of you. We have been discussing a lot about how a negative PSMA PET can spare an extended pelvic lymph node dissection or can't spare it. But what about a positive PSMA PET? Are there scenarios where actually a positive PSMA PET can prevent the patient to receive a useless lymphadenectomy? John, do you have a comment on this?
Yeah, I agree, but I think it's very much up to, this is an area where we don't know. And how is it positive? Is it positive with large nodes? Because that would be a different positive than a positive with a small node. And you could also say that you would be positive with large nodes, but negative PSMA PET. So, I mean, this is a jungle that we don't really know. I mean, then you would be positive in conventional imaging, but you will be negative with the PSMA PET. So if you have 15, 20 millimeter nodes, and so all these three would be positive, but in different ways. And that, like we discussed here, some kind of PSMA RADs, how likely is it that these lymph nodes are positive is absolutely imminent. And I think for the positive ones that we deem positive, like if it's PSMA RADs or whatever we will call them, and if it's a 3, 4, or 5, then maybe you should, and if it's very few of them, then this is where we need trials to do lymph node dissection or radiation therapy, or even, it was a very interesting paper by Tevari and his co-workers in Nature Review Urology here just now, that when they talked about that taking the lymph nodes out could actually impair the lymph node, the immunological defense, and that you could maybe target therapies for these lymph nodes mets. But we don't know. Basically, the short answer is we don't know. We need studies in this area.
Yeah, we should also base our decisions on guidance, obviously, which are based on level 1 evidence. And in this regard, the results of the Tuger trial, which you presented very nicely, and which are actually supporting a role for an extended nodal dissection in terms of metastasis-free survival, are likely to change the guidelines. And the second point is, what about the fact that all these trials are actually comparing an extended nodal dissection and to a limited one, but we don't have actually trials telling us that removing the nodes or not removing the nodes at all, as many of us are doing in case of negative PSMA PET, is actually safe.
I agree that we need the trials where we compare to no nodal difference. I mean, the difference in median number of nodes taken out in the Tuger trial is 12 versus 14. So the whole difference would be change of taking 2 more nodes out, which is, well, that sort of makes the whole study in the end a little bit difficult to interpret, I would say. But we are desperately waiting for the proper publication of this M1 results and to see how we can interpret it, because it's one thing to see an abstract at a meeting and a completely different thing when it's published and you have the peer reviews and actually scrutinizing the results back and forth in a different way. So before we have the proper publication, I don't think it will change the guidelines, but it's very interesting. We're waiting for it.
Thank you. And going back to positive notes and to Irene, actually, I just wanted to know a comment on the rate of false positives, because we have nomograms which are mainly relying on negative PET, but when we have positive PET for a patient like the one you presented with a grade group 2 disease, and we have a positive PET in the nodes, when should we think about a false positive result, and we should not deny a curative intent treatment in a case like this?
I think here it is very important to know your distribution of potential metastasis. What I see again and again, and I completely also agree with the notion of Gianluca, we need a lot of teaching to read PSMA PET CTs. So if you have an inguinal lymph node with an SUV max of 3.5 and somebody tells me because it's above 3, I call this a metastasis. That's definitely bad. If you have an obturatoric or iliacal, internal, external, pararectal, presacral, and please don't confound it with the ganglias, positive node that is really more active than the background, the specificity is really high. This needs some knowledge about anatomy, but if you know this, I really went through so many lymph nodes, and I had one lymph node that was truly false positive. It was some strange inflammatory reaction in this lymph node that was PSMA positive. But this is really something you encounter very rare. So the specificity is high, the sensitivity is not perfect, but also, and I fully agree with this, should we still offer surgery? Yes, no. Should we then take the notes? Yes, no. Very difficult question to answer. However, if you think that you really can reach them easily, why not? In our cohort, usually this went quite well. If it was a common iliac node, don't touch them anymore. This is bye-bye. Train left the station. But if it's still the real N1 and it's easy, not the pararectal, but if it's an obturatoric node or an iliacal node, yeah, then why not? If the patient wants to have surgery, but it's a good argument then also for radiation oncology, I think.
Yeah, and I think there could be, you would reach more nodes, and it's very unlikely that it's not just going to be this one node, because they start off as really small nodes somewhere that we don't find. And I'd really love to see the studies where you compare the radiotherapy to beds compared to the lymph node dissection in these patients also, because maybe radiating in larger area would be more beneficial, but as I said, I don't think we know. I don't know anyway, and I haven't seen the studies for that, unfortunately.
So that the concept of common iliac nodes you were mentioning is actually something that we also observed in PN1 patients. And we got a question actually on the chat about the management of a patient with an enlarged node at MRI. In that case, the patient, regardless of PSMA expression, is a CN1 patient. So we know that the guidelines are quite clear about the fact that surgery may not be the ideal option for this specific case. Gianluca, do you have any comments on PSMA quality? How do you deal with, in Italy, you know, we get PSMA scans from all around the country, and I'm sure it's the same for you in Udine. So how do you deal with it? Do you have a tumor board which is able to review all images, and which is your experience in terms of MRI quality and obviously PET quality?
Yeah, so our center just started using PSMA PET 1 year ago. So I think we are not bold, and so we are still in the phase of learning, and our physician, nuclear medicine physician, are still in the phase of learning. Of course, these are completely change our way to discuss patient within our multidisciplinary board, which is on site, I think, since 20 years. And I think the positivity in the lymph nodes, probably rather than outside the pelvis or to the bone, has really got complicated our discussion. And of course, this is a continuing learning process. But I do agree, and we start also seeing PSMA PET perform in other centers that are probably younger than us. And of course, these are completely difficult to interpret, and our decision is now to, unfortunately, to repeat the exam. We don't know whether we do good or wrong, but in many cases we had to repeat the examination de novo. So I don't know the experience of other, but sometimes you have difficulties in assigning the label of metastatic to a patient, probably when the technical requirements probably you know already in advance that are not standard.
Yeah, I completely agree with you. And I think we should push our nuclear medicine physicians to adopt standardized ways in terms of reading images. We see patients, and this was my next question actually to Johan and Irene regarding the role of conventional imaging, because the message we get not only from the guidelines but also from this kind of activities is that now PSMA PET is replacing conventional imaging. So Johan, can we actually apply results obtained in studies where patients were staged with conventional imaging to this new era of PSMA PET? Isn't it too risky to treat a patient with a novel RP or chemotherapy because of a positive PSMA without information obtained at the bone scan, for example?
We need once again, we are in a complete lack of studies when it comes to comparing these two. And that is what we need. We need studies where you have both the conventional imaging, you have the bone scan, and you compare it to what would that mean in the PSMA PET. Because a low volume metastatic disease or high volume makes no sense when it comes to this. You look at the bone scans, and you count 5 METs or 3 METs, and it's low or high volume, and you can choose different METs. It's a completely different thing if you look at the PSMA PET. And I mean, you go back to the Declan Murphy and the others' papers on the PokeMets. Do we need to catch them all? It's from the editorial from a few years ago. I mean, we don't know. I must say again, it's very difficult to write the guidelines when we don't really know. We know some things, but there are gray areas or even black areas where we really, really need studies to compare this. So what does it mean? And but it's not going to look the same in a few years. That's for sure anyway.
Gianluca, comment on this?
I think it is important to say that there is a great initiative going on that goes under the name of SPARK, and also led by the ESOU. And it is an initiative trying to harmonize all the published or available so far reporting system. We have the PSMA rates, the PROMIS, the one by the EANM. So I think this is a great, should be and will be, of course, a great step forward in speaking the same language and using probably different tracers, but I mean, ensuring high quality for our MDT boards.
Well, I agree completely. We need to speak the same language.
I fully agree with that, but I also think that, let's face it, the low tumor volume and the high tumor volume burden was really assessed in a very, very kind of rude way.
Oh, yeah.
It was,
absolutely.
Yes, but I also think now, as we have PSMA PET, I sometimes just are shocked. I mean, a patient comes in, has nodal disease up to the supraclaviculary nodes, and it's really, the whole retroperitoneum is black, but just because it's not larger than 5 centimeters, nobody considers this high volume. I think we have to rethink what is high volume disease, and the only way to do this now, because nobody is going to finance a prospective randomized trial where we then do treatment based on the PSMA PET. That's not going to happen. But I think what Wolfgang Fendler is trying at the moment, that's the way to go. We have to collect data, a lot of data, and he's doing this, 10,000 PSMA PET scans. And he already could show that those PSMA quantitative markers, they are heterogeneous. It's not all very nicely standardized, yes, but still they are meaningful. And I think this is something we then have to rely on. And based on those values, we might be able to convince drug companies to then do prospective trials.
Gianluca, one very short last comment. We are out of...
And also a word of caution, meaning that not all prostate cancer are expressing PSMA. So probably we don't know whether these, we have very few data. These tumors are doing worse or better, we don't know, or the same, but I think we also desperately need some other markers to be integrated in the clinical pathway. So this is sometimes what we see now, we are starting to see in our MDTs, and so we see some histologically proven metastases that are PSMA negative, provided that the quality of the PET is high. That's another
But
point.
Gianluca, I would in a short way argue that we already have that. We have the PSA. If you don't do the lymph node dissection up front, and you have a 0 PSA afterwards, then you don't have metastasis. And if you have a measurable PSA, then you can do your lymph node staging later on if the PSMA was negative from upstart. It's completely plausible to do just as good lymph node dissection 3 months later, and it's very unlikely that that's going to change the outcome for the patient, in my opinion.
Yeah.
One might
I know these arguments, but
the immediately after surgery is low, but at a certain point, the patient can recur in the nodes. Maybe the burden of a metastatic disease in the nodes was too low to be detected immediately after surgery, and the performing a nodal dissection at the time of surgery could have hypothetically improved the outcome. But again,
possibly, but not for all the
we don't
patients
know.
that had negative lymph nodes, and that's the point. You
Yeah.
do it. Yeah.
It's an area where we really need randomized trials, and
Yeah.
we need randomized trials designed in the PSMA era, which is not easy because the data we have now basically rely on patients diagnosed 10, 15 years ago. So it's
So true.
but I'm sure, and as Irene was saying, collaborative efforts are needed to prove that quality is key also when we talk about PSMA, not only about MRI. So quality and quantitative and qualitative measures are needed to talk the same language and to have the same, or let's say, standardized management for our patients with a proven oncological efficacy. With this, I'd like to thank you all for this very nice discussion, and thanks to all our participants. The webinar will be online if you miss a part of it, and thank you again and have a good night.
thank you. Bye-bye.
Thank you.
Goodbye.
Bye. Bye.